Okay, so here's our recap. Everything we've been talking about is all right here. All right, it's kind of organized for us, so we know that, respiratory acidosis here. All right, so for respiratory alkalosis, what causes respiratory acidosis? Someone is breathing fast or breathing slow. Someone's breathing slow, hypoventilating, is someone that's, or low tidal volume, low respiratory or low tidal volume, will make us have a respiratory acidosis. Why does that happen? Who gets it? What are the causes, right? So they have increased CO2 due to decreased respiratory or tidal volume or decreased minute ventilation because they maybe OD'd. They OD'd on fentanyl, they OD'd on benzos, it was iatrogenic, we gave them too much morphine, and they were morphine naive or opiate naive, and that can cause them to stop breathing, right? And then they have a CNS lesion, right? All of a sudden they're not breathing. Then as a rapid response nurse, we go up there, what'd you give? What'd you give? Did you give this? And then they realize, oh, they have a stroke. That's why they're not breathing, right? They had a massive stroke. So that could be the reason why they are hypoventilating, right? Or we have something neuromuscular. The myasthenia is getting worse. So Guillain-Barré is getting worse. And in Guillain-Barré myasthenia, we do Q4-hour vital capacities. We assess how much air they can get out from a full breath. Right? So if that air is less and less and less and less, that means they are more and more risk of hypoventilation, hypercapnia, and eventually they are, they can stop breathing. Okay, because the CO2 eventually builds up and builds up and builds up, makes our pH go down and down and down. Enzymes don't work, and they just shut down, right? And they got a tired respiratory patient, right? Because down here in respiratory alkalosis, where you're breathing fast, breathing fast, breathing fast, that's because of an SNS response, right? Anything SNS will make me breathe fast. But it's like, well, why is it in both sections? I thought hypoxia was down here causes me to have respiratory alkalosis. Well, this is like a tired patient, right? There's someone that's been hypoxic for a second, and they were respiratory alkalotic for a while, and then they were compensating because they're blowing off CO2, and then eventually they just tire out, right? And then now you're hypoventilating. All right, so we see that on rapid responses. We see that in the ICU. We're monitoring that for a while. We might put them on BiPAP therapy, and we say, okay, we'll see if you do better. And we can see the tidal volumes go from 400 at the beginning of the shift down to 250, down to 150. Exactly a change of shift, perfect time to intubate, right? That's why we're monitoring the tidal volumes. Okay, and then we have increased CO2 production. This is like extra, it's a little more advanced, where they have like hyperthyroid that can make your CO2 start going up. Okay. Yeah, the hyperthyroid situation. All right, fever can do it too. And yeah, fever causes a respiratory alkalosis, but there's a little overlap there. All right, so what are their symptoms? Your SNS is going to fire off. They're going to be tachycardic, they're diaphoretic, they can be pupil dilated, sure, but they might be hypertensive. They're hypoventilating, they got the SNS response firing off. All right, and late signs are someone who's tiring out, right? So there's a late sign of a respiratory acidosis. Okay, so why is it on both? It's like, well, first the SNS response is for the respiratory alkalosis, and then they're going to start tiring out until the point where they just stop breathing. Okay, and how do you fix hypoventilation? Yeah, hyperventilation. You're going to fix it, right? You can fix it by ventilating them. We can maybe do BiPAP if they meet criteria. Otherwise, they may need intubation, right? Sometimes we have to give naloxone, and what do they have to do?
Wake up! Wake up! Wake up! Wake up out of your sleep! Wake up! Wake up!
They need to wake up. They need to get Narcan, right? So Narcan, if they got benzos, the alternative is another medication to reverse lorazepam, I said benzos. Narcan to reverse opiates, or romazicon to reverse our benzos here, right? So we got flumazenil here, we got naloxone here. These are guys who are going to fix someone who is not breathing, right? And then a hypoxic patient, if that's way too hypoxic, we can try giving oxygen, bronchodilators, and diuretics to try to fix them, but they probably are on the verge of intubation. All right. When we give reversals, we have risk of them causing seizures, so it's something to consider. If they have seizure disorder, sometimes we might give just one dose or not at all. All right. The benefits don't outweigh the risks in that situation. And just so FYI, COPD, they sometimes are just already hypercapnic. That's what they are at baseline. They're already respiratory acidosis, and we'll touch on that later. All right. They're just chronically respiratory acidosis. They're chronically retaining CO2. All right. Respiratory alkalosis, again, they are breathing way too fast. And why they're breathing fast? It's just all the things we talked about for SNS. All right, they're hypoxic, they are hypoglycemic, they're hypotensive. All these things are triggering them to breathe fast, right? How do you fix that? you're going to fix it, right? You're going to fix the underlying problem. They got low oxygen, give oxygen. They got low sugar, give sugar. They got no kisses, but they have what else? They have a low blood pressure, you can raise the blood pressure, right? With a bolus or vasopressors, right? If they have anxiety causing it, we can give anxiolysis. We can break their anxiety and hopefully not give too much where we then need a reversal agent, right? And again, these guys can tire out and they can then now be on the respiratory acidosis side. All right, so switching gears, metabolic alkalosis and acidosis, right? So these guys are patients that are building up something or losing something, right? So in metabolic acidosis, they are building up acids or they've lost bicarb, right? So they've lost bicarb or they've built up acids. So again, the acids are the acids that will kill you: ketones, ingestions, lactate buildup, uremia because of acute kidney injury, or hyperkalemia, right? They go into renal failure. That can cause them to be, the hyperkalemia. Maybe they're getting potassium without their Lasix, right? That they forgot to discontinue the potassium also, right? That can independently raise our, make us go into metabolic acidosis. And then loss of bicarb, as I mentioned, they got GI diarrhea, right? They have excessive sodium chloride, will do it as well, right? So that's why we don't usually give sodium chloride in a patient going to the ICU. They found that if you give sodium chloride boluses to everybody, the ones that go to ICU die more versus the ones that go on the floor, it's fine. But the alternative to normal saline is what medication? LR, right? So LR should really be our goal fluid in the ICU and the ER for patients being admitted to ICU. Okay, and we'll talk about that more in renal. We talk about fluid balances and such. All right, and low pH. This is acidosis, right? And low pH does what? That's one of our stimulants of the SNS. So we're going to have all the symptoms of the SNS, right? They're tachycardic, tachypneic, diaphoretic, etc., right? And then we're going to add some extra things on top of that. On top of those SNS symptoms, we are going to have ketosis symptoms or DKA symptoms. When you're DKA, you have abdominal pain, you have Kussmaul respirations, you have fruity breath, and then SNS response, right? That's just it. Those are your DKA symptoms. When you have lactate elevation due to sepsis, you have now fever, and you have maybe they have cool extremities. They could have probably the SNS response, but initially, usually with early sepsis, they'll have warm extremities. And diarrhea causes dehydration. Dehydration drops your blood pressure, and dehydration can also, that's going to stimulate your SNS as well. And then renal failure, they're going to have the symptoms of renal failure, right? If they're chronic, they might have itchy skin from uremia, or they might have like really high phosphate. There's other symptoms that are included with someone that has a low pH and renal failure, right? And for each one of these, you're just going to fix them, right? And each one of these we're going to talk about in different lectures, right? We're going to talk about endocrine and DKA. It's fluid, insulin, and electrolytes, FIE. That's how you fix DKA with fluid and insulin. With lactate, when we talk about sepsis, you're going to give LR, right? Not NS. And you're going to fix septic shock. With vasopressors, you're going to fix sepsis with antibiotics, right? If someone has diarrhea, you're going to fix the diarrhea only if it's not infectious diarrhea. So we test it for everything, right? We test it to make sure there's nothing, no ova and parasites, no C. diff, no anything else. And then we can go ahead and go give antidiarrheals. And then renal failure, we're going to fix the underlying cause. If septic shock was the cause, then we can then fix the septic shock. Otherwise, we might have to do dialysis, right? And the potassium cocktail we can give if they are hyperkalemic. Okay, and then acidosis we can assess on the chemistry. So that's something that's free, or not free, but it's something that we can look at and see the trends and see if they're getting more and more acidotic. And of course, monitoring lactate and monitoring, making sure the MAP is greater than 65 will avoid lactate for building up. Okay, so because perfusion to the tissues, it's either hypoxia or low perfusion, but low perfusion is low O2 delivery to the tissues. It doesn't care. It just says, I'm not getting oxygen. I'm going to start making lactate.
Also,
right?
It's not necessarily a byproduct of
No, mitochondria will shut down when there's no O2 delivery. So there's no O2 delivery either when you have raging pneumonia or you have raging hypotension, right? It doesn't know the difference. It just knows I'm not getting O2. Okay. And then alkalosis. So you gain bicarb because of antacids, or we have hypokalemia due to potassium wasting diuretics, or they're vomiting or have diarrhea with alkalosis, metabolic alkalosis.
They have vomiting.
So they're vomiting out all their acid, and now what's left behind is too much bicarb, so their pH goes up or down. pH goes up. Good. All right, so how do you fix that? They're hypokalemic. Hypokalemic, give potassium. If they are and you still need diuresis, we can give acetazolamide, or we can say let's stop it, right? Sometimes also sodium bicarb drip that's unchecked can cause this as well. That's why assessing on chemistry what the bicarb is will help us. Okay, and then if we give antiemetics to make them stop vomiting, we got to monitor QTCs, which we'll talk about more in cardiac. Okay, so ABGs. So we're gonna have you interpret some ABGs, and we'll take a break, and we'll come back and we'll discuss ABGs as well. But how do you do ABGs? For those, most of you should be familiar with ABGs, but just a quick recap is you're gonna look at the pH first. So the pH is low or high. So if it's low or high, it's probably, we're gonna say it's acidosis or alkalosis, right? That's our very first step is it acidosis or is it alkalosis, right? Sometimes it's normal, and we're gonna come back to it. If it's 735 to 745, we're going to come back to it. But if you can say, if it's 739, you can still say what? Acidosis or alkalosis? You can still say acidosis. I'm still going to fill in acidosis if it's 739. 740, you can't. You can't make a judgment. Okay? You have to get another ABG, right? You say brief. All right? So yeah, so pro tip, if pH is normal and other values are normal, it's a normal ABG. Right? So then we can stop right there, right? You wouldn't say, oh, it's normal acidosis, right? You'd say, no, if that's normal and the other things are normal, I'm not normal. Right? So, but if the other things are abnormal, all right, I'm going to say acidosis or alkalosis first, and then I'm going to see what made it acidotic or alkalotic. I'm going to try to match it up. All right, did the CO2 cause the problem, or did the bicarb cause the problem? So in this ABG right here, I got 732. Is it acidosis or alkalosis? That's acidosis, right? And then I got to say, well, which one caused it? Did 49 cause it, or 29 cause it?
49 go.
So 49, we think of CO2, think of CO2 as an acid, so I'm building up acids more than 35 to 45, so I have an acidosis on my hand. So that's acidosis. You can have mixed acidosis where both of them are acidotic. We'll touch on that on the next slide. But for the most part, it's probably going to be one or the other. So that's what causes acidosis. 29 is which one? Right here, what is that, alkalosis or acidosis?
That's basic.
That's alkalosis, that is acidosis, right? So what caused my pH to be acidosis? It was my CO2. And if CO2 causes the problem, that's always respiratory, right? And this over here is more academic. You don't usually see someone say, oh, that's a non-compensated, partially compensated. No one's going to say that in real life, right? They will say mixed, so we'll touch on that in the next slide. But no one's going to say, oh, is that fully compensated, partially compensated, or uncompensated, sir? That's not a usual question that gets asked, right? But how do you know which one it is? It's based on what is the other one doing. So we know that this one is acidosis, right? We know it's acidosis here. Acidosis, and is the other one trying to fix it or not? Did it get off its butt to try to fix the problem, or is it normal? If it didn't get off its butt at all, or is it abnormal? If it didn't get off its butt at all, it's just still 22 to 26, then we know that it's uncompensated. It didn't do anything to try to fix the problem. But if it got up its butt, it's trying to fix the problem, right, which it is, right, it's 29, it's trying to fix this acidosis. That is partially compensated or fully compensated. How do we know it's partial or full? It depends on the pH of the next step. So the pH is normal, it fixed it, full compensation. If pH is abnormal, it partially fixed it, right? It's not there just yet, right? So again, you're trying to find out who caused the problem.
So this would be an ABG of somebody that's been chronically like hypoventilating or something.
So yeah, so this CO2 is high, right? So CO2 being high means they are hypoventilation. So, and then maybe they are trying to get diuretics, right? Or they got too many diuretics, or maybe and that's what made them alkalotic and they're breathing slow because of that. But you can go either way, but they're acidotic in this situation. So respiratory acidosis and the bicarb, it's been happening for a couple days, right? They've been trying to compensate overnight or the next day. They've been trying to fix this respiratory acidosis, okay? And then remember, O2 is not used in ABG analysis, never used, all right? O2 and CO2, I didn't mention the first slide, they're just like two ships passing the night in the alveolus. You need them to work there. They just look like night shift and day shift going. They have no effect on each other, right? They don't, there is the SNS response that happens, but there's nothing like says, oh, my O2 is low. There's no direct mechanism that makes the CO2 get changed, right? That's not a direct mechanism. Maybe very indirect, but not a direct thing. But you don't need PO2 to make an ABG analysis, but you can use it to figure out why they got the ABG, right? The PO2 is 50 in this patient right here, right? 65, that's not great. So they're probably on the hypoxic side, right? They're starting to build up acid because they're probably not able to compensate for the hypoxia. instructions here, but basically you're going to say what is the cause of this, what is my interpretation of this ABG? Why are they, what is this? Metabolic acidosis, metabolic alkalosis, what is happening here? Okay? And then what may have caused this? You have two possible causes of our situation here, right? Why do they have this? Are they have DKA? Do they have renal failure? Are they breathing too fast? Do they have diarrhea? Are they vomiting? So we're trying to figure out give me two different reasons why they have this ABG, right? And then how are we going to fix it on the ventilator, right? There's two ways to fix a oxygen on the ventilator, right? Which two ways? Oxygen? PEEP and FiO2. Rest rate and tidal volume are going to fix my CO2, right? So let me know how you're going to fix these patients on the ventilator. What's something that can be adjusted? Okay. All right. So who has number 1? Those of you guys working number 15, you got about 15 minutes. All right. Number 1. What do you got?
We got metabolic acidosis.
Good. So we got acidosis up top here, right? We got and what caused it, right? You can even just go right down. Right. It's 24 is alkalotic. This is acidotic. Bam, boom. Right. So if bicarb's causing it, it's metabolic acidosis, right? So metabolic acidosis is our interpretation. You could go one step further and say partially or fully compensated, but really the only times what I would hear clinically is if it's mixed or not, right?
We got causes of diarrhea or DKA depending on the gap.
Good. So diarrhea, we're losing bicarb, right? And DKA, we're gaining acids, right? Both of those are going to drop the bicarb. Either the bicarb is going to start neutralizing the ketones, or the bicarb is being lost, and you're left with a more acidotic serum, right? And then I just ask, how do you fix it?
Increasing respiratory rate.
Good. So to fix bicarb, let's blow off some carbonic acid, right? Blow off some CO2, and that'll be the way to do it. And to do it, you have to increase on the vent. If they were vented, you would do what?
If they were vented.
Mm-hmm.
We would increase FiO2 and no, the 60 is already there. So.
To blow off more CO2.
Yeah, increase respiratory rate.
Yeah, increase respiratory tidal volume. But when you have a CO2 at 24, that's pretty much the lowest you want to have. You don't really want to have less than 28. So that's CO2 is really dangerous right now. So really our goal is to fix an underlying cause. You said DKA. How do you fix DKA?
Insulin.
Yeah, so it's FIE, so like Fee-Fi-Fo-Fum, so it's FIE, fluids, insulin, electrolytes, right? That's how you fix DKA, right? This patient has a PO2 of 60, which is not normal, so that's why it says increase FiO2 or PEEP if this was done on a patient on the ventilator. But again, 60 is acceptable, so we might be able just to monitor that for now. We'll continue to monitor, all right? So then next one, ABG part number 2.
Respiratory alkalosis?
So this is alkalosis. Just going right down. CO2 at 30. Is that alkalotic or acidotic?
That is alkalotic.
Alkalotic. And this bicarb 23 is acidosis, right? It's in the acidosis side of normal, right? So because 24 plus or minus 2 is normal, right? So we got which one caused it? The one that has alkaline twice, right? So we have what kind of ABG? If a respiratory problem. If CO2 caused the problem, it's respiratory, right? So it's a respiratory alkalosis. And PO2 is 90, so that's probably not due to like hypoxia, right? So with a respiratory alkalosis, you're thinking of what causing it?
This is like a hyperventilation from anxiety or...
Yeah, so from something something that stimulates the SNS, right? There's things that stimulate the SNS, and there's things that happen because of the SNS. So you got to make sure you're on the right side of the fence, right? Because when the sugar's low, the SS is going to fix that by raising the sugar. When the blood pressure is low, the SS is going to fix that by raising the blood pressure, right? So yeah, so get 2 examples. What might be the AB?
Pain.
Pain.
Anxiety.
Good. Yeah, PO2 90. You're thinking it's probably not a hypoxia issue. It could be blood pressure issue on the low side, but you might start seeing like you see the acidosis. Maybe it might get worse with low blood pressure, or they have like you said, they might be getting more. What else? You got to get a blood pressure, blood sugar. It could be a blood sugar issue, right? But if they're vented, how would you fix this?
This is a decrease in respiratory rate.
Yeah, we can decrease the respiratory tidal volume. This might be someone on the ventilator simply, and we just got to make sure we adjust the respiratory tidal volume. Do you have to change it the O2 or PEEP?
No, because
No, PO2 is perfect, right? If the O2 or PEEP are actually high, it'd actually bring it down, right? Like we said last time, you want your FiO2 at least less than 70%. Okay. So you got a hyperventilation, anxiety, pain, distress, and asthmatic, right? Just a note about asthmatics, right? They should be always alkalotic, respiratory alkalosis. Have you ever seen an asthmatic and they get an ABG result that says respiratory acidosis or interpreted acidosis? They need to be intubated for one, or we need to escalate therapy immediately, right? That is never good. So, and even we look at the CO2, even before they become acidotic. If the CO2 is anywhere close to getting more than 40, then we're going to consider escalating rapidly or intubating. Okay. All right, number 3.
This is a mixed acidosis.
Good. So we got acidosis. CO2 of 55 is greater than 45. CO2 is an acid. It's too high. And bicarb is being utilized, right? Or it could be lost. But what do you think is going on with this patient?
This is like well, it depends, but it's, I guess you could do COPD or like late sepsis.
So sepsis causes lactic acid production, right? Lactic acid can definitely make their CO2 their bicarb go down. And then why would their CO2 go up if someone has sepsis?
The bicarb is neutralizing the...
No, the bicarb is not compensating here. This is someone that's definitely not compensating. So they're acidotic, and then they're also acidotic, right? So something's not clicking. So something else is failing.
Yeah, nothing's confusing.
So this could be someone with a PO2 of 45, right? I'm thinking hypoxia. You can think of any reason for hypoxia. You said COPD with pneumonia, COPD exacerbation, COPD with a PE, right? When you have COPD exacerbation, up to 40% of the COPD patients have PEs, right? So it could be a PE, right? And it could be, but would a PE cause a bicarb 15? No, I would say probably lean more towards pneumonia, right? Like a really bad pneumonia causing sepsis, and this could be a COPD or that's kind of tiring out, right? They're tiring out. They've been on BiPAP for overnight, and then their CO2 starts climbing and climbing and climbing because they're tiring out, right? They're hypoventilating. So it's a septic patient that's hypoventilating, a septic patient that is also hypoxic. So it's like, well, what else is going on? You can have a UTI and a PE, that's allowed, right? So it could be a UTI with a PE and they're hypoventilating, right? They're an overachiever. They're doing all the things, right? So it's that is a sick patient, right? They need to be intubated at this point usually. Okay, that's one example, right? It could be hypoventilating septic patient found down. They could have aspirated. Okay, RRT for hyperkalemia, because hyperkalemia can lower your bicarb, right? Bicarb's low because of hyperkalemia. It's things that will kill you, right? So we could say a DKA patient that also aspirated. That's why their PO2 is low. Okay, and they're not breathing because they got a dose of morphine for their abdominal pain, because that's how DKA patients present sometimes, right? So they're vented. They probably should be vented. This looks like a ventable. Remember the 50-50 club, right? That's usually you're going into the 50s with the CO2s. You're going down for the 50s and the PO2s. It's probably intubation territory. Time to intubate. All right. So if they're vented, what are we going to do with them?
All things.
Yep. So oxygen and FiO2. FiO2 and PEEP. We can improve the oxygen, right? We'll increase that a little bit. And then what else? Rest rate and tidal volume we can increase, because both of those will improve ventilation. That will hyperventilate and blow off the carbonic acid, right? If it was someone that got like narcotics, like a DK patient, we can try to reverse it, right? So if they got benzos, how would you reverse it? You give Romazicon or flumazenil, right? And Narcan for opiates. All right, number 4.
So we thought it was compensated metabolic acidosis.
So you got acidosis there, right? It's like, well, 739 is normal. Remember, if it's less than 740, it's acidosis, right? And this is acidosis. And then what about the 30? Is that alkalosis or acidosis? That's alkalosis. So what caused it was our bicarb. Therefore, it's always metabolic, right? All right, so metabolic acidosis. So what caused it?
We were thinking sepsis or DKA.
So sepsis, DKA, and they're probably breathing fast to compensate, right? So yeah, this is a it's a fully compensated metabolic acidosis right now. But yeah, so they're breathing fast to balance that bicarb of 18, All right. Who else could it be?
Maybe like a dialysis patient.
It could be a dialysis patient that's anxious, right? So you got a dialysis patient, and maybe they missed dialysis, and they're fluid overload a little bit, and they're anxious. They're breathing fast because of that, right? Breathing fast because of the acidosis, also breathing fast because they're anxious, right? And then how would you fix that if they're vented? Really, I would say we'll continue to monitor, but I would make sure that the respiratory and tidal volume were okay, because to make sure we don't want that respiratory and tidal volume to go which direction. Where do you not want it to be?
You wouldn't want the respiratory rate
You don't want to be over oxygenated.
Oxygenation, yeah, is important, but respiratory and tidal volume, you want to make sure that it is not too low, right? If it's too low, that's going to make it acidotic, right? They were compensating, so we want to make sure we're kind of matching that, and that's important. Like when we intubate a patient, we take away all their ability to breathe fast, right? They're breathing 36 breaths a minute beforehand. We need to somewhat match that afterwards, because they're breathing fast for a reason, right? They could be breathing fast because they're anxious, but usually when they get intubated, we've already ruled out anxiety, right? Usually we say there's a reason why they're breathing fast, right? You don't like match 36, but you match like 24 maybe, right? All right, good. So then we talked about the vent and everything. Okay. So we got a DK patient with acoustic small breathing. We got a uroseptic patient because it's not a pneumonia, right? With tachypnea. All right, so the number 5. Good, we got acidosis. Acidosis. What about the bicarb? Alkalosis. So what caused the problem? So OD, yeah. So they're breathing slow, right? They got a respiratory acidosis, and they're breathing slow. They're breathing slow because they overdosed. So if they overdosed on let's say hydromorphone, what would you consider the reversal? We give Narcan, right? Naloxone as a reversal agent, right? What's another reason why they would be hypercapnic? COPD. So it is true that COPDers do have a high CO2 at baseline, but at baseline on the outside before they come to the hospital, if their CO2 is really, really high, like in the 60s at baseline, what other number do you expect to also be high? Yeah, bicarb. Bicarb at 26 doesn't really scream a CO2 retainer, right? So that's one of the clues. You see someone comes with a bicarb of 30, 34, 38. It's like they're probably a CO2 retainer, and that's the patient you're going to be cautious with of giving 100% oxygen and making sure they are well supported. Okay. So yes, another reason besides overdose, it could be a COPD patient that's getting worse, but it could also be someone besides overdose. What else might it be? Near drowning. The PO2 is 70. Maybe they're on the ventilator at this point, but yeah, they're not breathing for a reason. Okay. So yeah, so they're hypoventilating. They're not waking up. A massive stroke, so a neuro situation, right? So they either overdosed, right, and then you cornered everybody in the room as the RRT nurse. You cornered everybody, got a heat lamp going. It's like, did you give Narcan? Did you give any opiates? Did you give this? Because my Narcan's not working, right? So then she's like, well, then no, they had a stroke, right? Or they have like a worsening myasthenia crisis or something to that effect. All right, number 6.
Yeah, this one was compensated respiratory acidosis.
Good. It's on the acidosis side. We got acidosis here, and we got what here? Alkalosis. So this looks like a COPD patient, right? That bicarb is super high, probably compensating. How do we know a COPD patient is compensated? The pH is normal, right? Usually they'll accept more than 730. But yeah, the pH is normal. CO2 is on the high side because of the bicarb, right? So it could just be a COPD patient. What else could it be?
Like we said, we talked about like the stroke, like a neuro patient, or maybe somebody who has had a PE for a few days.
Yeah, the PO2 is on the low side, but it could be someone that has a acidosis because they could be fluid overload, and someone is giving diuretics for like 5 days in a row, right? Because diuretics do what change these numbers? How do diuretics affect these numbers? Like furosemide, for instance. Good. They pee out potassium, right? K and hydrogen have a relationship, right? If K is up, hydrogen is up. If K is low, hydrogen is low, right? So K is low, alkalosis, right? And if I lower the K more, my alkalosis is get worse, right? So this might be someone that's getting too many diuretics, right? And then because PO2 is 60 is probably like a CHF or end-stage renal, it might be a little fluid overload, okay? And they're acidotic because maybe they're slowing down the breathing, they're getting tired of breathing so fast for a day or two, okay? So then how do you fix this if they're on the ventilator?
Increase the respiratory rate.
Yeah, it's fix acidosis is caused by hypoventilation. So we're going to hyperventilate them, right? We're going to increase tidal volume or respiratory rate. And PO2, we can improve the FiO2 or PEEP a little bit. Okay. So yeah, CO2 patient with pneumonia or too much Lasix. All right, number 7.
Number 7, respiratory acidosis.
So we got acidosis, and then what else? CO2, is that acidotic?
Yes.
Yep. So that matches up. Just a quick look at the bicarb. Is that acidotic? Bicarb at 30? That's alkalosis. So it wasn't that caused the problem. It was definitely the respiratory acidosis situation. So why would someone get respiratory acidosis like this?
COPD.
Could be a COPD again. What else?
Thinking maybe some like neuro changes.
Yeah, it could be a neuro patient is not breathing well, right? A pontine stroke or something to that effect. Okay. Again, another excess Lasix situation, excessive PCA use on the floor. This is why we don't usually do PCAs anymore, because it causes respiratory acidosis. It has a built-in end-tidal CO2 monitor, just so we're alert to it. And that's our next section. All right, so number 8. What is this? 750. Is that alkalotic or acidotic?
Alkaline.
That's alkalotic. And CO2, 55?
That's
Acidotic. And this is 40 is what?
alkaline.
Alkalotic. So what caused the problem?
Maybe like excessive vomiting.
Good. So metabolic alkalosis, right? So someone that's vomiting all their hydrochloric acid. This would be for a while. It's probably be like an NG tube situation, or that'd be the reason why they'd be losing all the hydrochloric acid. Good. And it could be a COPD patient as well, and that's also going to worsen their situation. But they're trying to compensate, right? They're trying to breathe slower and slower and slower because they're more and more and more alkalotic. So that's why the CO2 would be high. Okay. And yeah, it could be a COPD patient as well, and if they're alkalotic, all right, the COPD patient with a bicarb of 40, you expect their CO2 to be much higher, right? So if we corrected the CO2 too fast, then that bicarb of 40, they might be expected to be like at 75 CO2 at their baseline. And we have them all the way down to 55. There's like, well, I'm alkalotic. The only way I'm going to fix 55 is breathing slower, right? So intractable vomiting, right? NG tube to suction. All right, number 9.
Acid.
Got acidosis up here, and then what?
Acid.
Acidosis, and then what?
Alkalosis.
Alkalosis. So we have 2 acids. A CO2 causes a problem that's called respiratory acidosis. So why does this patient have respiratory acidosis?
Possibly a PE.
Could be a PE. That PO2 looks mighty sus, right? PO2 of 40, that's a problem, right? And they're probably you expect when the PE to be breathing fast, right? So this might be someone on late stage, right, where they're really tiring out at this point, right? They were really hypoxic when they came in, and they are trying to, now they're really, really acidotic. But bicarb at 38, would that happen right away? You could say a COPD patient, maybe. That's why their bicarb was already in that situation. But what's another reason? Could be like what we talked about before. They're getting too many diuretics, right? And they were hypoxic, and they're trying to compensate, and they can't, right? So PO2 of 40 could be a pneumonia patient, a COPD patient with pneumonia, a COPD patient with CO2 retention, and then they also have a pneumonia on top of that, and they're breathing fast, and they can't really catch up, and now they're going to retain more and more CO2. Okay. All right. So next one, number 10. So we got acidosis.
And then, sorry, that one is more.
That's normal. What is it, on the alkalotic side or acidotic side? alkalotic side, right? And the bicarb is on the acidotic side. So that is metabolic or respiratory acidosis. It's metabolic acidosis, right? So what caused it? Could be diarrhea, right? They're losing their acid out, they're using their bicarb out their acid.
DK.
It could be a DK patient, right? CO2 at 36, right? They're breathing a little bit fast. I expect the DK by the 36, but a little bit lower if they're really trying to compensate, but they are compensating, right? Partial, or not even, it's actually uncompensated because they're not there yet. If it was 34, they'd be partially compensated technically. PO2 at 55, it could be a pneumonia patient, a DK patient with pneumonia, right? Or it could just be a straight up pneumonia patient, right? That's breathing fast, right? So they're trying to compensate, trying to breathe faster because they have a really severe pneumonia going on, and the PO2 is low, and and the pneumonia is producing this lactic acid because they're getting hypoxic, and it could be causing low blood pressure, and that's making our bicarbs come down, right? And that bicarb coming down is what caused the metabolic acidosis. So how would you fix that on a ventilator?
Increase tidal volume.
You can increase the tidal volume or rescue rate if you need to kind of help compensate, right? So usually you'll accept all the way down to like 28 on the CO2. So we have a little bit of extra wiggle room to kind of blow off a little more CO2 for them. Okay, so sepsis, pneumonia, DK patient pneumonia, severe diarrhea. Okay, all right, next one, number 11.
Also metabolic acidosis.
So we got on the acid side normal, and we got acidosis here, right? And there's also similar, right? That's alkalosis. PO2 is 210 though, so it's not like pneumonia or PE or something like that, but this is an acidosis from, this looks more like a GI situation, right? And what kind of GI situation would it be?
Like you're talking about diarrhea?
It would be diarrhea or vomiting. Which one?
Diarrhea.
Diarrhea. They're losing bicarb, right? They lost the bicarb, and then they're not quite breathing fast right now, but they could be if they keep having the excessive diarrhea, right? And PO2 at 210, we probably put them on oxygen, right? Because they were maybe breathing fast, a little anxious, but that's not the situation right now. That's not the cause right now, right? And then number 12.
Respiratory acidosis.
So we got acid, and we have acid, and we have 25 is just alkalosis, right? So we have a respiratory acidosis. Maybe. It just looks normal.
I know, that's normal. We were like, oh, is it
Yeah,
normal?
that's just normal.
Okay.
Okay. Okay, normal ABG. Continue to monitor. Number 13.
pH is alkalosis.
Alkalosis, good.
PCO2 is on the lower side, so it's more alkalosis.
So there's an alkalosis side, and the bicarbs.
It's high, so it's alkalosis. We got metabolic alkalosis.
Good. So it's like a mixed alkalosis, really. So there's two things going on, right? So we have two things causing that alkalosis. So how did that happen?
We put as well like vomiting and also excessive use of diuretics.
Yeah, it can be vomiting, and they don't like it, and they're breathing fast because of it, right? PO2 68, is that normal?
Yes.
Someone that's vomiting and aspirated, right? So they're aspirated, their PO2 is low, and now they're still vomiting, right? And they're breathing fast because they're hypoxic, right? So that's a mixed alkalosis. Okay, vomiting patient, right? And then to fix it, if they were vented, we can reduce the respiratory rate and tidal volume, right? All right, number 14, what's this?
So pH is alkalosis.
Alkalosis,
PCO2 is alkalosis.
that's alkalosis.
And then bicarb is alkalosis.
That's on the low side, right? So low bicarb is acidosis, right? So that's trying to compensate for the alkalosis, right? So what happened here?
We're thinking maybe they're hyperventilating.
Yeah, they could be hyperventilating because they are, well, if you're hyperventilating, yeah, you get all the way up there, you got some circle or moral paresthesia. Why are they hyperventilating?
It's like an overrented patient. Huh?
It could be our error that we had the respiratory and tidal volume set too high on a septic patient. or it could be like before they got vented, what might be going on.
Like, no, they didn't.
Like respiratory, like pneumonia.
Yeah, pneumonia PO2 is on the low side, so it could be like, it could be an early, like they have a sepsis process going on and they're just compensating for it right now, right? So they're compensating for it. They're breathing way too fast. It could be anxiety, right? Bicarb 20 makes me think it might be something else occult happening. Okay. All right, hyperventilating, anxiety, pain, agitation. So we're going to continue to monitor this. All right, bicarb 20 is a little curious. They could be a renal failure patient. All right, renal failure patients can have anxiety. It's allowed. Okay. And number 15, what's that?
pH is acidosis.
That's acidosis, and then what?
CO2 is on the alkalosis side.
Alkalosis.
And then bicarb is on the acidosis side.
That's definitely acidotic, right? And then what is that?
Metabolic acidosis.
Metabolic acidosis due to?
Could be these do diarrhea.
It could be severe diarrhea to get down to 6.98 pH. So usually when you see someone that's awake and talking to you that has 6.98 pH, they're usually what kind of patient that develops acidosis? DKA, right? Diabetic ketoacidosis, right? The ketones are building up, and that's causing the acidosis, right? So that's likely what's going on. Okay, so they have a DKA patient. And then number 16, what's going on there?
This is a dead person. I'm just, this is a mixed acidosis.
So we got mixed acidosis. We got all acidosis here, right?
And judging by that spike in CO2, it's probably like a ROSC.
So yeah, this is actually the same patient as bed 15. This is a real life example. So it's a DKA patient that asked for Dilaudid, right? And we gave Dilaudid versus fluid insulin electrolytes. So this is like, hold off, we'll get your pain under control, but we need to fix the underlying problem first, right? Because you gave the Dilaudid, now they're not breathing that well, right? And if you're not breathing that well with a pH of 7.34, you're like 7.30, right? 7.28 maybe. But that 0.06 change from, that's going to cause a lot more problems when you already have an acidosis brewing. Okay, so this is a patient, yes, that coded because we gave pain meds for a DKA patient that was really, really, really severe.